Alrighty, so hey guys, this is Kelly. Today we are going to be talking about chronic pelvic pain. So there's two lectures you'll be listening to today. First one is obviously by myself, and then Ben will be doing the second one if you're watching them in order. So my part of this will just kind of be a general idea and talk about chronic pelvic pain. So to start out, we're going to go through our learning objectives. So today we're going to, number one, discuss the scope of chronic pelvic pain. Two, understand basic definitions of pain nomenclature. Look at individual biases regarding chronic pelvic pain, and then a basic anatomy and neurophysiology review that you'll commonly see in regards to chronic pelvic pain. So to start out, we'll have our definition slide. So one thing about chronic pelvic pain is there was really not a consensus on what the definition should be. So depending on who you talk to, it might vary, but according to UpToDate, it's defined as non-cyclic pain perceived to be in the pelvic area that has persisted for at least 6 months or longer and is unrelated to pregnancy. So variations I've seen on this definition are whether it's non-cyclic or cyclic, and then the timing it has to last for. So I also see 3 months is enough to meet criteria as well. And then obviously unrelated to pregnancy. So just to discuss the scope of the problem, it really is a vast problem that affects many women. So a couple different studies I read. First one said that it affected anywhere from 6% to 25% of reproductive age women. Another study I read said it affected 1 in 7. But the big thing that I saw is not only does chronic pelvic pain account for 10% of referrals to gynecologists, but it is responsible for over 40% of gynecologic diagnostic laparoscopies. So this isn't just, they're going in there, a treatment type thing. It's women coming in with chronic pelvic pain and they're actually having to have some type of surgery to even diagnose what they have. And then finally, another study I read that just noted that in primary care practices, over 39% of patients reported having some type of pelvic pain. So next, I just want to kind of focus on how much chronic pelvic pain can affect quality of life for individuals. This was a study I found done by the University of Florida that looked at 2,000 college-age women. And what this chart kind of shows is just how many aspects of their lives were affected by this disorder. So anywhere from physical health, mental health, limited activities because of their pain, sad days, worried days, not having enough sleep, not enough energy. All these things were much more common in people that had ever experienced pelvic pain versus the people who had not. And then generally just how people rated their health was a lot lower in people who had pelvic pain. So this just kind of shows how much chronic pelvic pain affects so many aspects of quality of life for individuals. And this is also kind of just going off of it, but when you treat someone or look at someone with chronic pelvic pain, you really have to look at the whole picture. And so not only do they have this underlying biological process going on, but it can really cause prolonged suffering, marital and family problems. So if someone's having severe chronic pelvic pain, they may be hesitant to be intimate, and that can definitely affect their marriage or relationships. They can have loss of employment or disability, and then there's various adverse medical reactions people can have from lifelong diagnostic things and therapies and treatments. So it really is a big deal, I guess. So this was just another slide that I found, or a picture that I found, that kind of showed how things kind of expand on each other. So with chronic pelvic pain, you have this underlying insult or tissue damage that causes the individual to sense some type of pain. Their thoughts then become very focused on this pain since it's this constant thing. Many times different emotions will arise because they can't get a diagnosis. It's impacting relationships, so now they're suffering, and then they kind of turn into pain behaviors. So maybe not being able to go to work or needing narcotics to treat their pain. And so it really just builds on this underlying issue of some type of insult. Next, we're just going to talk about some of the biases that come with chronic pelvic pain, and we're going to look at it from two perspectives. So the physician biases you might see, as well as patient biases. So in regards to physician biases, When I spoke to Dr. Hedges, things she commonly sees is patients coming in saying that physicians don't really believe their pain, they're saying that it's just in their head. The reason this is, it can often be very difficult to find a cause of someone's pelvic pain, and it can be even more difficult to treat. So physicians may just feel powerless to even help the patient, and so they start to just kind of say, I don't find anything, there's nothing there, deal with it. Also, many of these patients have a history of narcotic abuse, and that is a lot of the times because of their chronic pain they are dealing with. And so then physicians are reluctant to treat them, thinking that they're just drug seeking. And then in regards to patient biases, patients who have a history of trauma, specifically any type of sexual abuse, may fear seeking help or really be unable to seek help because of pain and emotional stress and really not being able to have anyone touch them like that. And so it's very, very stressful for them, and really it can be embarrassing for them as well. So this is a very private, personal matter for patients. Then the idea of going in and talking to someone about it can be difficult for many patients. As I mentioned before, they can have a fear of both the testing and the treatment because oftentimes these are very invasive procedures they have to go through. And then, as I mentioned before, they also are often unable to get a diagnosis. And so Dr. Hedges mentioned that a lot of times patients will come in, see a doctor once, be told, they can't figure out the cause, and then they'll just never seek help again, and they'll just chronically live with this pain. So next we're going to move on to pelvic pain nomenclature. And some key things you want to understand when defining pelvic pain is, number one, is it cyclic or non-cyclic? So this is asking exactly what it sounds like. Is it something that happens every time during your menstrual cycle, at the beginning of your menstrual cycle? Or is it something that's kind of sporadic, that it just hurts all the time, it's random? So you really want to be able to define it in that way. And then kind of going off of that, you want to know, is it menstrual or non-menstrual related? So this is the same thing where you're looking at, is this something that has to do with menstruation? Or could it be something related to your GI tract or your urinary tract? And then not only if it's related to your menstrual cycle, but when in the cycle does the pain occur? And so why we want to know that is, if you guys remember from studying for step 1, what Mittelschmerz is, but what it is it's one-sided pain that occurs in the middle of their cycle when they ovulate. And so many people won't associate this with basic menstrual cycle type symptoms, but it is when they're ovulating, and it's a normal type of pain people can feel. Secondary, in adenomyosis versus endometriosis, in adenomyosis, the pain is often associated with the actual bleeding, so all during your period, versus in endometriosis, the pain is often in the beginning of your period or more like premenstrual type symptoms. And then finally, you also want to know if it's provoked or non-provoked. So do things like intercourse cause it to be more painful? Having a bowel movement, urination, what things causes the pain, or is it just something random that hurts in general? And then last thing that Ben will talk about more, but I just want to mention it here, is the APQRST model. And what it does is it breaks down how you want to discuss the pain and identify the pain. So you can see associated features, provocative, palliative, quality, radiation, setting, and temporal aspects. And just something that Dr. Hedges also noted is that with endometriosis, this isn't like a board keyword thing at all, but something that she has noticed in her practice is that people with endometriosis will often describe their pain as a V-shaped pain in their pelvis. So just something to take note of. Other key words that you will hear when discussing chronic pelvic pain are dysuria, dyschezia, dysmenorrhea, dyspareunia, and dysesthesia. So with dysuria, this is pain or discomfort during urination. Dyschezia is going to be pain or discomfort during bowel movements. Dysmenorrhea is going to be pain or discomfort during menstruation. And then dyspareunia is going to be pain or discomfort during intercourse. And then dysesthesia is kind of a different one where what it does is when someone touches the skin, say it's like a light touch with a cotton swab, instead of the person feeling a light touch, they'll feel severe pain with it. So kind of how Dr. Hedges described it is your nerves sending the wrong signal. So instead of sending, light touch, it's very painful for the patient. Next, I just want to discuss a little more about the study I mentioned earlier. So it was titled The Attributes and Barriers to Care of Pelvic Pain in University Women. And as I mentioned before, it looked at a total of 2,000 female students at the University of Florida. In total, there was 284 women that reported having pelvic pain. And what this part does is just kind of breaks down what the most common complaints were. So number one was premenstrual pain. But we also saw a significant amount of bowel-related pain, deep dyspareunia, vulvar pain, pain after menstruation, and deep pelvic pain after intercourse. So what this kind of shows is which ones are most common, but also how many different types of pelvic pain there can be. Because all of these were pretty common. So it's just good to take note of really what is causing their pain and really getting a good explanation of what their pain is. Also, this was kind of interesting and sad, really, that only 75 of the 284 women who experienced pelvic pain reported having seen a doctor. So that's only 1/4 of them ever saw a doctor for one, and nearly 80% of these respondents lacked diagnoses for their pain. Just some of the reasons that the women cited for not seeing a doctor was, number one, difficulty with insurance coverage. They also cited perceived lack of physician knowledge, training, or comfort managing their conditions. 10% said they had difficulties getting appointments with the appropriate physicians. And 10% noted a perceived lack of physician empathy or interest in their conditions. And just one other note that I found interesting is that among the students who reported pelvic pain, those that were sexually active perceived their physical health and mental health to be worse. And this just kind of shows that how much chronic pelvic pain can impact people who are in relationships or intimate, and it really can have a big impact on their overall well-being. This was just a nice model that I found that kind of shows how multifactorial and complex chronic pelvic pain can be. So you have this underlying biological insult such as endometriosis, interstitial cystitis, or adhesions that you chronically are dealing with, which builds into having anxiety, depression, or if there's past abuse in there, and leads into more social impact on them. So it impacts the relationships. Different beliefs can stop them from seeking care, and different cultures may have a stigma in dealing with these things. So when you're looking at a patient with chronic pelvic pain, you really have to look at the whole picture. Last, we're just going to finish up with some anatomy and neurophysiology review. So first, we have to start out with innervation. Number one, vaginal secretion production is going to be innervated by parasympathetic nerves of S2, S3, and S4. And then contraction of uterus, vagina, and sphincters are also done by S2, S3, and S4 as well of your spinal cord. However, when looking at sympathetic innervation to these muscles, so uterus, cervix, and vagina, those come from T11 through L2 of the spinal cord. And finally, just sensation of that area is also going to be innervated by S2, S3, and S4. So this slide is just an illustration of that if you're a more visual person. But you can see sympathetic coming from T12, L1, and L2, and then your parasympathetic, and they don't have sensation on here, but parasympathetic coming from S2, S3, and S4. So this is just a picture from Netters in regards to the pelvic floor. There's a lot of things obviously labeled on here, but I think key things that you want to take away from this is the levator ani muscles, which are the main muscles that support the pelvic floor. And those are made up of 3 muscles, which is puborectalis, pubococcygeus, and iliococcygeus. And then just shows you kind of the main anatomy outside of that. And then this is just another picture of that in more simplified terms, but gives you a good idea of what the anatomy is of the pelvic floor. So this slide here is just looking at the pelvic anatomy from different views. And big things I want to talk about here are just looking at the ligaments of the uterus. I'm not going to go through all of those, but key things you want to look at is where the round ligament of the uterus is at, because specifically in pregnant women, they may experience round ligament pain. And also looking at the recto-uterine pouch of Douglas. So that's a pouch, obviously, between the uterus and the rectum. But this can be a potential space for fluids, whether it's blood or whatever. So if someone has a ruptured ovarian cyst, things like that, you can get fluid collections in these different pouches, which can cause irritation to the whole area of the pelvis. So that's just important to kind of recognize how many structures are there. And then the picture below just shows kind of location of where the uterine vessels are in regards to this, as well as the vesicular fascia and obturative fascia. And we'll talk more about this in the cases as well on the next slide, but patients can often experience fascial pain, so it's just good to take note of where these fascial planes lie. So the last slide is just looking at the fascia some more, as well as the potential spaces. So as I was mentioning before, the fascia area can be a common place for myofascial pain in the pelvic region. And pretty much what this is the patient has some type of insult in their pelvis, so whether it's ovarian cyst, interstitial cystitis, endometriosis, IBS, some sort of inflammation in there. And this inflammation and just pain sensory expands into their fascial planes. And so even when the initial injury resolves, this pain can often still exist in the myofascial area. And so it's important to recognize that even though a patient may have had this, injury in the past, they may still experience pain from it, and you might not find anything on exam. So it's just important to know. And the last thing I just want to touch on here is just looking at this picture is how many organs and, there's an ambulance going outside. Just a second. How many organs and body systems are in the pelvis. So you can't automatically jump to some gynecological cause. So you have your bladder, very anteriorly there you can see, and your uterus and your rectum and your colon and the vasculature and the ovaries. And so it's really good to look at the whole picture of what could be going on when a patient presents with chronic pelvic pain. So that's it, that's all I have today. These are my references here, and a big shout out to Dr. Hedges, who is super wonderful in helping us with all of this, and she will be here on Friday to help answer any questions you guys have. And just finally, this was a good TED Talk that I found on chronic pain, not specifically pelvic pain, but I think it's a pediatric anesthesiologist that just kind of talks about it, and I found it interesting. Definitely not required to watch, but if you have time, might like it. So I guess next you'll be watching Ben's video, and we will see you guys Friday. All right.